Good evening, everyone, and welcome to the webinar going through the COVID-19 transition in the IVF lab. How can quality management help? Organized by the ESHRE Special Interest Group Safety and Quality in ART. Today, Dr. David Mortimer will give a presentation on this topic, and Dr. Daniela Nogueira will be the moderator of the webinar. You can enter your questions in the chat box, and we can go through them after the webinar. We will record the webinar, and after it, you will receive an email with a certificate of attendance and the recording. Dr. Nogueira, I give the floor to you for the introduction.
Thank you, Titia. Hello, everybody. Good evening or good morning, depending on your location, of course. Hoping all of you and those around you are doing okay and that you are hanging on in good spirits to overcome this strange COVID period that we are all going through. I'd like, first of all, to thank ESHRE and the special interest group SQUART, Safety and Quality, coordinated by Kelly Tillemans, to give me the pleasure to open in their name their webinar session of today, which is about how to cope with the COVID crisis in the IVF laboratory. Therefore, I would like to introduce to you Dr. David Mortimer, now who probably most of you know he is one of the pioneers in our field. I will just give you a short summary of his biography, otherwise I could spend the whole webinar telling about his background. David is going to actually speak from Vancouver, but he's originally from the UK, where he obtained his university degree and PhD in zoology. Thereafter, he expanded his horizons internationally during his several postdoctoral fellowships and landed in Australia, where he was a scientific director of Sydney IVF for 9 years. He's a past president of the Canadian Fertility and Andrology Society. He was also an associate editor of Human Reproduction Update. He has been an active member of ART accreditation in Canada already for over 10 years and has been honorary senior lecturer of the School of Medicine in UK since 2017. David is the author of about 300 conference presentations and 160 publications about andrology, IVF, and risk management in IVF laboratory. He is very much specialized in creating optimal micro and macro environmental IVF laboratory conditions, and together with his wife, Dr. Sharon Mortimer, he established his consulting company, Ozoa Biomedical, 20 years ago, and ever since, and is still at his young age of today, he has been working on designing new ART laboratories, cryobanks, helping to develop quality management programs, advising companies in developing products, and thus, David keeps helping IVF to progress. So I leave you all with this promising, interesting lecture, and I'd like to kindly ask you to post your questions during the presentation. I'll do my best to expose as many as I can to Dr. Mortimer during the QA session. So David, if you're ready to go, the screen is yours.
Thank you very much, Daniela. Everything working okay on the screen? You can see this title slide?
Yes.
Good, thank you. So good morning or good afternoon, everybody. It's 8 o'clock in the morning here and the end of the working day for all you people in Europe. It's a pleasure to be here. I'd like to thank the SQUART of ESHRE for inviting me to give this presentation. And since we want to maximize the time for questions, I'm going to get straight into it. So you've got the title. We have the usual conflict of interest statements that we always give out. Yes, we are consultants, but we're also still academics at heart. And what we're saying, certainly in this webinar, has no commercial or financial interest whatsoever. So the focus of the presentation, I'm not simply going to reiterate the content of all those response plans that people have been publishing from various professional societies and the return to normal, or the new normal as it's being called. I want to look at some general approaches based on TQM principles that everybody can use to analyze and answer their own questions, and then use that information to devise updated processes and systems within their particular circumstances. Every clinic is different, and so I want to avoid being too prescriptive, but help people develop the approaches for working out their own issues. The focus is going to be lab operations. So I'm not going to talk about delaying treatment for at-risk cases. That's a medical decision, and we're staying on lab aspects. In many respects, I'm going to assume that labs operate according to the expected EU Tissues and Cells Directive requirements, that they employ safe working practices, including work with liquid nitrogen, make proper use of PPE. So this little thing saying normal with a green background, this will pop up on various slides, and it's just the points that are often seen in these various response plans, but for me, it shouldn't be anything different to what you do normally. It might be reminding you to pay extra attention to it, but it shouldn't be something that is extra or different. The main theme and the main message is that you need to ensure that the focus remains on the core objective, which is the care of the gametes and the embryos. Our goal is to make the best embryos possible, and that's what we must focus on, regardless of what we're trying to do in terms of pandemic control. And so my real goal is to illustrate how the lab's quality management system can give confidence of safety in the post-closed down world. I'm not going to say a post-COVID-19 world. We are nowhere near a post-COVID-19 world. Who knows if we ever will be. But the point is, right now we're looking at how to come out of the close downs and work out how to reinitiate services. I'm using TQM as the guide. TQM is just the philosophy of how we manage things. It rests on the 3 pillars of quality management and risk management and systems management. Quality and risk are 2 sides of the same coin, and the systems management is what allows you to actually make everything work. So in terms of reopening post-COVID-19, it's all about risk management. And if you think about risk as the possibility of suffering loss, then you can look at risk management as being reducing uncertainty about future events that can threaten an organization's ability to accomplish its mission. And so you're really just trying to make sure that things are safe. You're trying to ensure that everything is still fit for purpose. The facility and the equipment, the materials in terms of expiry date, stock rotation, supply chain, etc. We'll come back to these a little bit. And about the staff. And we have a risk of people de-skilling during long closure or furlough periods. So you need to make sure you verify competency in the staff as well. I'm going to talk more about SARS-CoV-2 rather than COVID-19. COVID-19 is the disease, SARS-CoV-2 is the actual infection. And in terms of the infection control procedures, it's about protecting patients and staff and the families of all those people, and about protecting the gametes and embryos, although probably not so much from the virus as from extrinsic factors we need to make sure still do not creep into our systems. The key tool that we're all going to be using in this respect is a failure modes and effects analysis, which we like to look at as proactive troubleshooting. You're looking to see how things might go wrong and try and prevent them from going wrong. It's how you optimize your systems on a routine basis anyway. The thing is that some of the choices that were acceptable pre-COVID-19 might now be less appropriate, but it may also be that some of the things that people want to put in place to achieve certain degrees of protection and safety may actually be deleterious for the embryos. So just as a general thing, in terms of how we look about initiating services, relying on self-reporting of symptoms and fever measurements alone is not foolproof. There are far too many asymptomatic infected people for that to be the sole measure. It's all you really can do because it's very difficult to organize proper testing for the actual infection. It needs to be done repeatedly using PCR, perhaps antigen testing for patients and staff. These testing platforms are not as widely available as we might have hoped by this time. And certainly the current antibody tests appear to have too high false negative rates for them to be considered reliable. Some places are saying we want to run the tests in-house so we can actually make sure we've got enough throughput or access to testing. Remember, if you're going to run tests, you must have adequate competency to run those tests. And if you are just going to think you can buy a machine and a kit and run them, it's a little bit more complicated than that. And you can just fall back on ISO 15189 in terms of what you need to do if you want to try and set up those sorts of tests in-house. Obviously, self-reporting of possible exposure should also be practiced, and non-attendance of patients or self-isolation of staff should, in terms of most documents, be required. I would say you must encourage this. It's something that we really need to do. It's the single most important thing to do to reduce the transmission of the virus. But whatever you do, you need to seek professional advice from your local infectious disease and public health officials in order to ensure accordance with local circumstances and regulations. What works in one place may not be allowed in another one, or you may be required to do something different in another area. So you need to make sure that you are not just making your own plans, but you're following what the local authorities want you to do. And wearing masks, remember, it's always to protect the others and not yourself. So wearing masks is not going to give you a false sense of security. The biggest risk of infection in the ART lab workplace is the proximity to your unmasked co-workers, and this is simply based on the number of contacts and the contact duration to allow for transmission of sufficient virus particles for an infection to occur. Many people are still getting pregnant at home, so in terms of the patients, we don't have a contra recommendation like existed with the Zika virus. Andrology has a much greater need for face-to-face interaction with the patients than does embryology, because in andrology you need to verify the semen specimen provenance, as it was actually the man's, or his, if the one brings it, her partner's, and whether the sample is complete, as well as checking about the risk of poor specimen quality due to recent febrile illness. If these are not done, because you're just allowing the people to bring the samples in, drop them off reception and run away, then you are risking some of the procedures that you may have decreased for IVF rates, and we'll come back to that. Most embryology tasks are actually solo activities. Most of what you do in the embryology lab, you're working on your own. The biggest issue, though, is when you have witnessing, because that requires the closest proximity with colleagues, because they have to come and read the dish label. They certainly can't do that from 2 meters away. So this is obviously a clear advantage of electronic specimen identity verification systems like RI Witness and Matcher. The key shared contact items in the lab are microscopes, computers, chairs, and door or incubator handles. In terms of microscopes, a lot of these plans suggest that you allocate staff or workstations to minimize sharing. But a point made by Kelly Tillerman when we were putting this webinar together is, if you're worrying about that, how does that infection risk compare to, for example, you all getting changed in the same change rooms or sharing the same toilets in those change facilities? You've got a much higher risk of transmitting an infection there than you have by working at the same workstation or the same microscope. And our normal work practices in most labs have staff working at a single location across a series of cases. For example, you work at the same ICSI rig and do a series of cases. So cleaning the workstation when the operators change over rather than between cases is one of the options to be considered. Something that I think is an important issue that a lot of people don't think about is the microscopes. If you use things called high point eyepieces, and from this picture you can see that there is a little red arrow pointing at this symbol, there's a little picture of some spectacles engraved on the side of this eyepiece. Those are high point eyepieces, and the image is formed several millimeters further away from this lens. So they're designed so that spectacle wearers can use a microscope without taking their spectacles off. And this would allow anybody using that microscope to minimize the risks of contact around the eyes. And in fact, you can use microscopes while wearing safety glasses. So if you don't have these sorts of eyepieces, that would be a sensible thing to acquire to reduce the risk of possible infections via microscope use. Repeated cleaning of lenses is not that good an idea, because you can take off the coatings, you can damage the lenses just by scratching, and depending on what you're using to clean them, if you're using certain solvents, you risk dissolving the glue that holds the lenses in place in some models. So be careful of repeated cleaning, although you might find you've got spare lenses lying on the microscope. You can use video micrography in many places. The problem with stereo zoom microscopes is that if you put a camera on a stereo zoom in the image, you lose your depth perception. That's why we have the stereo zoom head, stereo microscope heads, stereo being Greek for solid, so it allows you to perceive the depth perception of where you are in the dish or whatever. There's been suggestions that people should just use CAST for semen analysis, but CAST systems have got a lot of limitations in terms of accuracy, and in fact, none of them have ever been fully validated against a reference methodology as in WHO manual or taught in the ESHRE Andrology SIG basic semen analysis courses. So if you're going to use CASA, remember the results you get will be different, and in most cases will have a much lower accuracy than proper reference methodology. Computers, the keyboards and then the mouse or trackball probably represents the major non-airborne cross-infection risk in the lab. And you've got some simple solutions: sealed keyboards or flexible covers for easy cleaning between users, trackpads or touchscreens rather than mice and trackballs. We could look at using sealed industrial panel or tablet computers. They're expensive, so it would be a longer term thing to do, but it's something we should perhaps think about for the new normal in the coming world post-COVID. Remember, of course, that VOCs are released from computers. Towers are worse than all-in-ones, which are worse than laptops, and tablets have the least VOC emissions. So just think about you should be thinking about what computers you're using in the lab anyway. So laptops and tablets are better to use than towers anyway. Direct data entry into a computer will minimize hard copy records, and because many labs put those in plastic folders or on clipboards, of course those would easily carry a viral infection on their surfaces over a prolonged period of time. And of course, the traditional issue is that if you have hard copy records, then you put them in the computer, you always have the risk of transcription errors. What hasn't changed in the lab is all those things that affect the ART lab operations already, in terms of environmental at the macro level and micro level, concern about your equipment, about the materials you're using, the methodologies. Here we've got to be careful that we make changes appropriately. Your operational policies in terms of delegated decisions and whatever. The staff issues are the same, and we have the same risk of errors. We would rather not increase that by anything that we're doing to try and reduce the risk of virus transmission. So in terms of the laboratory facility, the process they're going to use for reopening the lab will depend very much on whether the lab was actually closed, as in everything turned off, or whether it was just not actually functioning. If the lab was fully closed, then you will need to do a deep clean before you can start reactivating even the HVAC system. And if the HVAC system has been off, you should probably get that checked for Legionella as well. We don't want to follow COVID-19 with Legionella or Legionnaire's disease. Also, you're going to have to completely clean and sanitize all the equipment because it's been sitting in a dirty space. You should consider a complete disinfection of the space before you start. Some people are talking about using bioqual, which is a hydrogen peroxide vapor fogging of the entire space. Only after you know that the place is clean can you reactivate and then revalidate the HVAC system. So if it's been turned off, it's going to have to go through the whole process of measuring air changes per hour, pressure differentials, particulates, microbials, and VOCs all over again. If you just made the lab inactive and left the HVAC system still functioning, then you just need to review the HVAC monitoring data, example from your building management system, and you can then just reopen the space if the HVAC is operating within the expected parameters. I would still recommend verifying the baseline VOC levels, especially if you're doing a lot of restocking with fresh consumables. A deep clean should not be necessary because it is a clean room after all, so it should still be clean if the HVAC's been functioning and no one's been in there. So you might just need to do a routine clean down. You're going to need to review your lab equipment, and I'll cover that in the next slides. And I'm just going to remind you here that make sure that the equipment used for egg retrievals also gets the same review. And you're going to restock your consumables, rotating stock, discard expired products. That's all normal stuff. But you also might need to re-ensure the continuity of your supply. Make sure that the cold chain integrity is still going to be functional, because they may be using different shipping methods, different routings. There may be different risks of stuff sitting on the tarmac waiting for a plane, because there are a lot less airplanes than there used to be for transporting materials. And then make sure that the delivery practices to the clinic or into the lab are safe as well. In terms of the lab equipment itself, first thing, check the cryotanks. You should have been checking them anyway because that should have been happening, but just have another check and make sure that none of the cryotanks have been showing any diminished performance that might indicate that they're possibly going to fail. You can pick up most tank failures well ahead of them actually failing. If the lab was completely deactivated, then there's a massive amount of work to get done before the lab will be ready to restart procedures. But if the equipment was left running inside a functioning clean room, there's much less to be done, especially if you've had a continuous equipment monitoring system, which I think is a very good idea these days. We've been recommending them to people we've been consulting to for quite some time now. And obviously, you've got a wide range of possible permutations between those two extreme scenarios. So the restart process of the equipment will again depend on whether it was left on or it was all turned off. Then you may well have turned it off to save gases or whatever. So we're going to turn it on. Before you even think about that, to make sure that your test instruments are still in calibration. If they're not, they need to be recalibrated. This should be normal practice. You should always be checking that your test instruments are still in calibration. you're going to have to check the service or preventive maintenance records for all your equipment and call the engineers to come and do those services if necessary. Remember, once you're open, again, you're probably going to get a lot of patients coming through, and you don't want to be closing again in a few months to get some preventive maintenance servicing done. So it's better to get that done now, even if it's not quite in your normal timeline, but just to make sure you don't have to close down again. If the equipment was turned off, you need to completely clean and disinfect the equipment. Once the HVAC is then running again, you need to do a full performance qualification or operational verification on each piece of equipment to make sure that it is fit for purpose or still fit for purpose. If the equipment was left on, and I'm assuming here it was inside a still functioning clean room space, a deep clean should not be necessary of the equipment. Not just the room is the clean room, so the equipment should still be clean as well. Just a regular cleaning and sanitization as you do in your normal routine practice. If you have a continuous monitoring system, review the data to confirm everything is still operating within parameters. If you don't have a continuous monitoring system, then you have to run a full PQ on every piece of equipment to ensure it's still fit for purpose, that it hasn't drifted off calibration or whatever. So a lot more work. And again, this is why I think these continuous monitoring systems are such a great idea, because it's done automatically for you. And instead of you measuring it once, perhaps twice a day, it's logged every 5 minutes. So you have much more information on how the equipment is performing. Don't use alcohol-based hand sanitizer inside the lab. Even with a good HVAC system, the VOCs are totally contrary to desired outcomes for embryos. Alcohol-based sanitizers are usually recommended if you can't hand wash them. We should certainly be able to hand wash. Don't use alcohol to clean or disinfect equipment inside a working IVF lab. Use known embryo-safe products, things like OSafe, or use hydrogen peroxide. Make sure the biohazard cabinets are used properly. This should be normal because you're handling potentially infection material, just like you always were. Just that you now know one other species of virus that's going to be in there. Semen might contain SARS-CoV-2. There are conflicting reports, all based on low case numbers as yet. But we already expected to use class 2 cabinets for semen anyway, so that shouldn't change what we do. As far as we know, follicular fluid doesn't contain SARS-CoV-2. It didn't contain the SARS-CoV, the original SARS virus, 17 years ago either. You need to be aware of any possible aerosol generation, and we'll return to that in a moment. Don't rely on UV lamps inside biohazard cabinets. They are a mechanism, but they're not the best mechanism. And it's interesting that the NIH not only does not recommend, it doesn't even permit the installation of UV germicidal lamps inside biological safety cabinets at its own facilities. So if the NIH doesn't want them, it suggests that there are better methods for doing it. In terms of your lab personnel, obviously make sure that everybody knows and observes your updated human resources and infection control policies and procedures, especially updated PPE rules. Check all certifications, proficiencies, and internal QC activities are up to date, as you would after any prolonged period of time away, for example, if someone was away on maternity leave or had gone traveling for 6 months, which we look forward to be able to do that again sometime. Ensure that everybody knows and observes any changes to lab policies and procedures that you've introduced. So staff need to sign off on updated documents, and managers need to monitor compliance by observation. Not willful non-compliance probably, but just that people are so habituated to doing things certain ways. Doing it a different way is going to be a bit hard to get used to. You've got to verify that people's skills and competencies are current and provide remedial educational training as needed. For example, sperm motility morphology assessments, ICSI procedures, embryo biopsy. But again, this should be a normal activity that you would do anytime after people have not been working for a prolonged period of 2-3 months. Roster your staff as discrete teams to reduce cross-infection risks, but also have backup scenarios in case someone cannot work. Symptoms or possible exposure of themselves or one of their family members. And you need to minimize your in-person meetings. For the lab director or manager, caseloads need to be controlled to match the available staffing for safe working and to avoid stress or burnout. Don't create a toxic work environment, try to make a safe work environment. Keep things as calm and stable as possible. Remember that everybody's stressed with the lockdowns, family issues, parents, partners, kids, school, alongside the employment concerns, financial concerns. Be inclusive, explain your decisions, encourage questions from staff, discuss concerns. even if you're doing it from the four corners of your conference room, or if you're all doing it via Zoom. Doesn't matter, you should be inclusive and explain things to people. Key risk mitigation strategies are simple. Use physical distancing, washing hands, use your mask, protect others, PPE in situations with actual risk of infection from or to patients. Minimize distractions from the real work of the lab. You need your staff to keep focused on the details of embryology. So lots of new just-in-case rules, things that are not yet evidence-based, but you thought might be a good idea, they're more likely to lead to confusion and mistakes. And that is far more disastrous to the clinic and the patients than perhaps not achieving 100% infection control. Remember, it's not evidence-based, so you don't even know if these things would be effective themselves. In terms of lab procedures, review all the SOPs to ensure that all the risks of infection or cross-infection have been identified and minimized or mitigated as far as possible without needlessly compromising gamete or embryo quality or outcomes. Review with management and other departments how best to schedule patients and procedures in accordance with social distancing and necessary cleaning time. For example, all andrology collections need to be by appointment, not just walk in, drop off a sample for diagnostic assessment. Minimize face-to-face patient interaction. I know it's nice interacting with the patients. I'm sure they appreciate that, but I'm also sure that they would rather you weren't in their face. Minimize the sharing of equipment and devices between the staff during a shift. This goes from the rubber bulbs down the pipettes to the microscopes and computers. Maximize safe cleaning, and I said be careful of not over cleaning and damaging things, and perform a full sanitization at the end of each shift so that what one shift had is not passed on to the next shift. Consider the workflow within the lab to facilitate physical distancing, and perhaps reorganize the equipment within the lab to create a simpler flow. And you might even consider using floor decals to get people to move in certain directions so that paths don't cross, or that people are not going to come close to each other when they don't need to, because there's another way that may not be the way they've usually gone, because it's a few paces longer. We've designed labs for 35 years or more now, and what we've been doing always is looking at flow to keep things going in a single direction if possible, minimize paths crossing and that sort of thing. So that's fine. Physical distancing in some labs is going to be very difficult because many labs are very small, and that means you have to solve the problem by number of people, which may then impact the number of cases that you manage. In terms of andrology, you're going to have to balance the idea of off-site collection of semen samples against the risk of decreased sperm functional potential due to adverse temperature exposure during transport and the prolonged ejaculation to processing delays. This figure on the top right here shows some old data, but it's hamstring penetration test data, but you can see that between 30 and 60 minutes, samples will show greatly decreased sperm function. And that means your IVF samples really need to start processing them within a maximum of 30 minutes, and the absolute max of 60, but even by 60, some will be compromised already. You need to clean or perhaps, but certainly ventilate the collection rooms between patients. If you use photocatalytic oxidization air purifiers, which have a UV lamp in these rooms, things like this floor standing unit that we've been using for 20 years now, these actually kill airborne bacteria, viruses, fungal spores, and yes, they would also destroy the SARS-CoV-2 virus. Obviously, handle the semen in a class 2 cabinet with appropriate PPE, dispose of waste and used materials properly. This shouldn't be anything different to what you do already, because you're already working with suspected infectious material anyway. Use centrifuges with buckets of aerosol guard lids, and that's this sort of bucket. I know they're a pain using these lids, but they're there for a purpose. If a tube breaks or cracks, you have a risk of aerosol contamination. These should be used normally, and they're expected in many jurisdictions anyway. If you've got known or suspected positive cases, then you can use an HIV type sperm washing method. For example, density gradient centrifugation using this thing called the Pro Insert, which ensures that there is no carryover of seminal plasma into the palate. You can completely separate these things, so the leukocyte rich fraction is kept separate. So this is something to really consider. In terms of embryology, obviously there's a much lower need for face-to-face interactions with patients than you have in andrology. There is an unknown but likely trivial in terms of risk management, risk of infection via eggs and embryos in culture. So our concerns are very much more about co-workers. But remember, you must still ensure proper temperature control during any modifications to the OPU procedures, the egg retrievals. Allowing oocytes to cool at this stage can significantly decrease success rates. So tube warmers were important, they're still important, but if you're modifying your procedures, remember eggs and follicular fluid must not get below 35 degrees. Handling and discarding follicular fluid with care, extra care, well, again, this should be normal practice, so it should not be that much different to what you've already been doing, but let's just think about it again and make sure that you're focused on taking that care. Clean the workstation after every case. You did that already, but perhaps you might need to be more thorough, especially if you spilt some fluid. But then again, if follicular fluid doesn't contain the virus, that's not the issue here either. Don't contaminate the microscopes. That should have been working practice anyway. You can transmit the influenza virus very easily through microscopes. Minimize hard copy records and the cross-handling of files and clipboards, because that's another way you can pass things between people, even if you're wearing masks, face guards, whatever. In terms of cryobanking, sperm represent the biggest risk because there's a possible presence of SARS-CoV-2 in semen. So treat all ejaculates if they come from an HIV-infected man. Well, technically, you already should be. You should always be treating semen samples as potentially infectious. You might say, well, we always screen the man before we do the sperm banking, except for the cancer patients. Well, there's nothing that says that you can't have cancer and COVID-19. So would you handle all samples that way, or just those from known or suspected SARS-CoV-2 infected men? This is for you to discuss with your medical director and work out what you think is the safest practice. Sexual transmission of SARS-CoV, the old SARS virus, has not been reported, and it's a very similar virus, so the risk to recipients would be low from any virus in a semen sample that was frozen. Eggs and embryos have got minute biomass, so the likelihood of 2 or 3 oocytes or 1 or 2 embryos carrying the 1,000 virus particles that infect someone is very low, and this form of transmission of SARS itself has not been reported anyway. At least for positive cases, perhaps you'd recommend the use of sealed devices only. I have for many years preferred the high security straws because they are actually proven to achieve effective biocontainment. The material they're made of is virus proof, the seals are virus proof, to the extent that these are the devices people use to store Ebola virus, which is a much more scary virus even than SARS-CoV-2. So perhaps you should reconsider about using high security devices to protect all your specimens from possible future cross-contamination from liquid nitrogen-borne microorganisms. Cryostorage tanks contain frozen moisture from the air. That's the white sludge in the bottom. And this sludge contains bacteria and viruses from the staff exhaled air. So it may well contain SARS-CoV-2. High security devices can be stored safely in liquid phase, but for the devices, especially non-closed devices, we might want to reconsider vapor phase storage for infected cases, but undertake a full risk assessment with your medical director because thermal damage in a vapor phase storage is a much greater and more likely risk than viral contamination. When thawing, remember to treat all devices as potentially contaminated on their outsides and sanitize all devices before opening them, as you should have been doing already anyway. Clean and sanitize tanks regularly, if not using exclusively high security devices. Ensure a full risk assessment will be undertaken with the medical director, as the risk of thermal damage during cleaning, because you have to take all the specimens out of the tank and transfer them to another tank, is high, especially for vitrified specimens. So people will say, is the lab working after we've reopened? Well, you need to refine that question. Are the lab processes working normally? In other words, is everything as it was before? So this is simple. You just monitor your lab KPIs as you were before, using control charts. It'll take you a few weeks to get meaningful data because you've got to collect enough cases. If you're a big lab, it'll be sooner rather than a small lab. If you're worrying about the pregnancy rate, well, that's going to take longer. It requires clinical follow-up data, and it's obviously less useful to tell you if the lab's working properly. So you need to check your processes first, then wait for pregnancy information to come along. Because it's going to take 4 to 6 weeks for positive pregnancy test data to come along, longer for implantation rate, and longer for clinical or even ongoing pregnancy rates. And of course, if you're doing that, you need to make sure you've got the same case mix as you had before. This is all a matter of basic process or systems management, and this should already be inherent in your quality management system. So this slide I'm going to go very, very quickly. You can always review it on replay. How do you know if or when a process or system is in control? You need to measure it, and that's what your KPIs are for. You want to know how it's performing, you need to analyze it, and that's what your control charts are for, what benchmarking's for. This establishes the competency level, what you expect it to do, how well can it do, how's it been performing, how stable is it, has it drifted off recently. So all this is part of your routine use of control charts. And the challenge for you now is that you must know and understand all the factors that control the process to make sure they are achieved and maintained, even if you're making changes to reduce the risk of infection from transmitting SARS-CoV-2. And that means you've got to recognize and control all the adverse extrinsic factors to minimize their effects or eliminate them entirely. And that means you have to measure them. So control charts, I'm sure everybody's seen the control charts. Based on historical data, you've got your control mean and your warning and control limits, and you've got your benchmarks. This, if you look at you get the background to all this stuff from the Vienna Consensus published in HR Open a couple of years ago. And I'm hoping that everybody does use this technique already. If you're looking to use these charts to analyze your reopening performance, then you just continue as you were before. You've got your data from the first part of the year before you close down, and you just keep plotting on the same graph after you reopen. But whatever you're plotting, whatever, your control ranges still remain the same as they were before, because that's what you want to make sure you're performing the same as, and see how you're performing post-opening. So this is looking forward to June, July, August, September success rates. You need to verify operator competency. So, for example, each ICSI operator, you should look at, say, 10 normal cases, normal ICSI cases, and compare that to your lab's current control ranges. If the result you get is that operator's within the warning limits for the lab, that means it's okay because it's within your 95% historical performance range. If it's between the adverse warning and control limits, it indicates poor performance, you need to review it. And same as you would have reviewed it anyway. A value outside the control limits, which is outside your 99% historical performance range, indicates that remedial training or some extra practice is needed. So here's some fictitious data. We've got ICSI fertilization rate, and there's our control mean and warning limits on the orange. And we've got this issue here that A, B, C, and E are perfectly fine. They're all good. D is down here, outside the warning limit. So these four are okay. This one, operator D, and given the fact where these are in relation to control mean, this person was probably always the poorest operator, or least good operator, should we say, being nice. But now that person slipped, so that person needs to get some remedial training or get some extra practice. Their skills have just got rusty. So take-home messages. Well, our standard mantra: think like an embryo. Well, think like a sperm, think like an egg at the appropriate time points. Patient and staff safety are paramount. We must always remember our responsibility to the embryos and the health of the children that result from them. That is the IVF Prime Directive. That's what we're there for. You've got to verify your lab facilities fit for purpose before you reopen. Verify all the equipment is fit for purpose. Verify that the staff have not de-skilled during the closure period. And remember that biology controls everything that we do in the ART lab. So always consider everything you do in terms of respecting the biology of the gametes, the embryos. When you're redesigning systems for whatever reason, you must never lose sight of this core purpose. So before you make any process changes to accommodate external factors, undertake a thorough risk assessment using the FMEA technique to evaluate all the possible consequences of each change. Avoid inadvertent compromises and inadvertent errors elsewhere in your systems because of a change you've made somewhere to try and make something better, but it may have other effects in other parts of your system. Keep focused on the core work of the gamete and embryo handling, the specimen witnessing, and cryobanking. Minimize procedural changes as they increase the risk of errors. And at the end of the day, you need to balance, perform cases against, balance your cases against the resources, the available resources. If you're working in teams, you won't have as many people in the lab on a given day. So you need to be aware of stress for your staff and risk of burning out your staff. Don't create a toxic workplace by trying to make it safer for people. Thank you very much.
Thank you very much, David. It was excellent, very complete. Before I go to the questions, I have a question to you that's very general. How long do you think, because of course, most of these measures you presented, they are measures that we had to take, we should in fact take in account, and maybe the COVID period woke us up to pay a little bit more But there are other things, like you mentioned. A lot of laboratories are doing the sperm collection at home to avoid the transit of patients. We are using a lot of disinfectants at the lab, which I think is extremely important what you mentioned. And a message we have to put here is that we have to balance risk benefits and not take all the measures to completely avoid the SARS and compromise the quality of the embryos, right? But how long? But because you have then those measures that you should do it every day, and then you have those sperm collection at home, and then it can take long and lots of disinfectants. How long we are going to have less people in the lab? Because that's the most in fact, I think the most important thing nowadays is the human resources. We have the woman people power. How long do you think that we're going to go on in this phase of the COVID? Because for me, it's still unclear.
Well, let's answer the last part of that first. I'll come back to the sperm collection part after that. But the simple answer is, I don't see a real new normal coming along until there is a vaccine. Until then, the virus is still out there. We relax our diligence and it will pop up again. That's how viruses survive. So I don't think the new normal is going to be different to what we're doing right now. So what we're doing right now needs to be done in a way that is going to allow us to survive what could easily be another year. I don't know, until the vaccine is developed and validated and then manufactured and distributed. I think it's going to be quite a long time.
Because the point is that we are reducing the number of patients in the lab because we have less people. So I see it's a little bit of a striking moment. For me, it's an unknown question as well. So you think it could take a year? All this?
I don't know. I mean, we can take all the precautions. So I think I'll come back to the semen sample one now. With semen samples, if you do the same as they do in shops and you put up perspex screens at the window where you get the sample from the man, he's required to wear a mask. You're wearing a face shield. You don't actually contact the man. You get the specimen jar and you clean the outside of the jar. You have got good ways of protecting yourself from that, and you will not be risking compromise. If the sample is brought in from home and it's for IVF, then you have a risk of decreased fertilizing ability. You need to balance things. How you get more samples into the lab? You run appointments. You make sure that people are scheduled. You work things out. We have always run appointments around Andrology labs, going right back to the 1980s. But it's a question of planning. But I think that the capacity of any facility is going to be less than it was before. There's going to be a new dynamic in clinics. You can't put as many cases through if you can't put as many people into the lab. And I don't see that changing until we have some way of guaranteeing the safety of the staff, more from each other than the patients in this case. Right. So unless you quarantine your staff and have them all living in a residence, which is not going to work, you still have them as part of the community, and they are still exposed to those risks. Depends on where you are. You need to look at what the infection rate and what the R value is in your community and make your decisions based on that. Some places, I'm going to give an example, on Quebec and Ontario here in Canada, they're still getting hundreds of new cases a day. British Columbia is getting less than 10 a day.
Yeah, because it's going like this, huh? Yeah, it's
you know, as we've stomped on the curve and we're doing well. Our provincial public health officer is a rock star now. So we've got to balance those things. And I think if you're just going to have the guys bring the samples from home, that might solve one problem in one way, but there are other ways of solving that problem, but it creates another one, which is the potential of the sperm fertilizing ability. Perhaps your ICSI ones get brought in from home. That's a possibility. But your IVF and your IUI samples, I think, should be collected on site for the benefit of the patients. You give them the best chance of getting pregnant. If they don't get pregnant, they come back for another cycle. That just gives you more caseload to handle. So you need to look at this in a holistic sense. But I think that working in shifts, I think you're going to be working, if you work to 2 shifts a day, you can actually run 2 lots of retrievals in a day. There was a clinic in Australia, in Queensland, used to run 2 shifts a day. They did retrievals in the morning and another set of retrievals late afternoon, because the way the doctors worked in the medical practices. That could be a model that people should look at as well.
Right. So in fact, it will probably give us ideas that we didn't have before, right? Now, you mentioned clean and sanitize tanks regularly. Could you tell us how to do that? Because I think in practice it's not so easy to do this type of work, right?
The standard instructions are out there. Basically, you need to move your specimens to the spare tank. You should always have a spare tank on hand anyway. In the UK, that's required for your license. So that tank should be able to take all the specimens from your largest other tank. I always recommend buying the same type of tank, so you can simply just move the canisters from one to another. So your reserve tank should be kept cold but not full of liquid nitrogen, because if it's full you can't get anything into it. So you simply transfer the specimen, the whole canister, from one tank to another tank, and then you empty the tank you want to clean. When it's back at room temperature, you clean it, you wash it out, you clean it out with a sanitizing agent.
Yeah.
And then you then you empty it, it's dry, then you have to refill it with nitrogen, which is done very slowly as you would then in a new tank, and then it's clean.
And how often you think we should do that?
People say you should do it every year, whatever. Personally, we don't clean tanks because we've used high security devices for many years, and with high security devices there is no risk of anything getting into the straws or vitrification devices, and because they are sealed, they have effective biocontainment. In fact, they're accepted by many authorities as achieving independent storage, so you don't even need quarantine tanks with those sorts of packaging devices. So with those, you can, when you remove a straw for use or whatever, you can clean the outside with OverSafe, and you then extract the sample. But again, the risk of cross-contamination from the outside of those devices is low if you handle them all correctly according to the instructions. So you need to just review how people do things. But tank cleaning is something that many places do or are expected to do. With high security straws, it's not necessary, but you will have that sludge at the bottom of the tank. And if a tank is an old tank, it will probably have quite a lot of that stuff down the bottom.
And you mentioned the cleaning with peroxidase. There is a question here asking what's the percentage of peroxidase that we should use it for the cleaning?
Hydrogen peroxide, use 6%.
6%, right.
That's the standard stuff to use, and wear gloves while you're using it.
Okay, I have a question here from a clinician.
I'm sorry?
I have a question here from a clinician.
Yep.
She would like to know, it's Ariana D'Angelo who asks us if you suggest self-isolation of patients before, during, and after the IVF treatment because of the COVID, right?
I would suggest if they're investing their money in a cycle they don't want to get abandoned, it would make sense for them to self-isolate as much as they can. They still have to attend for ultrasounds and that sort of thing, so there is that exposure, but they should really I think shrink their bubble before they come in. They should be seeing as few people as possible, and then when they come in for their cases, for scans or whatever, you're controlling that. When they come in for their procedure, you're controlling what the exposures, and after they've had the transfer, then they should, why not self-isolate? I've been in lockdown except for essential things like grocery shopping for the last since the middle of March now, and I go out only when I need to. And fortunately, we've always worked from home in terms of our office, but it's just a question of paying attention. Forcing people to open up and circulate is only going to extend things, and that's being eloquently demonstrated in the United States, I'm afraid.
And she also asked if we could use alcohol, because of course, as an embryologist, we are all against using alcohol in the lab, but should you use it outside of the lab, just in the SAS or in the in the operation room?
They can use what they want outside the clean room, but if their procedure room has the same air system as the lab, absolute no. Anything they do in there is going to get shared in the return air and then recirculated back into the lab. Whatever they do in there is going to affect what happens in the embryology lab.
Agreed.
It's the same box.
It's an eternal fight.
Yeah, but if it's not in the same ventilation system, then it's up to them, whatever they do. But if it's a shared HVAC system, it's as if you are inside the lab, because the air that comes out of the procedure room, so it ends up back in the lab.
Good, exactly. So there is one person here, Sushil, who is asking you. Now it's not an easy question. No? I think what is the risk of transmission to embryologists if proper PPE are not provided? In fact, if there is no protection, what's the risk of transmission?
A lot higher than it should be. It's a simple answer. I can't calculate that.
It should be 100%. The colleague has a COVID.
Nothing's ever 100%. Well, even Ebola is not 100%. But if that can't be answered simply. It would relate to what is in your community. In British Columbia, it would be very, very different to what's in Toronto, and it would be even worse in Montreal, just because of the background levels of COVID-19. So you need to look at your environment and see where you are. But remember, as an employer, people are expected, if not legally required, to provide appropriate PPE to their staff. And under most labor laws, if that is not provided, the staff can refuse to work with no prejudice whatsoever. But
Okay.
that would be a question of looking at what the local laws and regulations are. But I can't imagine why anybody would be expecting staff to work without appropriate PPE. They always provided it. And yes, we didn't always wear masks when we were doing other stuff in the lab because we had other ways of controlling things. But remember, in the old days, the risk of infection was from materials and us trying to stop us infecting the specimens. The biggest risk now is our colleagues affecting us.
Tell me something, David. If you use horizontal laminar flow, because I had this question from a colleague, do you think that in this period we should then protect also our eyes in
Absolutely. We have not recommended, well, we never recommended, we've never used horizontal laminar flow hoods in 25, 30, pushing 30 years now. I think we use verticals, but yeah. with any horizontal laminar flows, that's certainly not a good idea. Yes, they were nice for protecting the specimen, but verticals achieve the same purpose with less risk to the operator, and same with class 2s. So I think anyone who's got horizontal laminar flow hoods should be getting them replaced anyway. I think they're not. They're not the best choice, but people should certainly be wearing protective things, should be wearing safety glasses, whatever. But again, if they're trying to use a stereoscope microscope with safety glasses, they'll have problems if they don't have high eye point eyepieces.
Okay, no, yeah, it's a colleague from Italy, and mainly in Italy. I also suggested her to cover. We also suggested her. Now I have a question from Fernando Prados. What do you think about ozone air cleaning?
Ozone air cleaning, so ozone gets spread, it reacts. Ozone is not a good thing to have in the embryology lab. So the question, so if it's ozone, which is O3, that would be dangerous to your personnel as well. It's not a good form of doing anything with humans anything biological in this space. If you want to clean and sanitize the space before reopening, seal it off and use something like Bioquell. That's hydrogen peroxide, so H2O2 fog that's put into the place, and that would be effective. But again, you have to close the space and let it ventilate before anybody can go back in again. Your best way of cleaning the air in your space, I mean, HVAC uses HEPA filters. HEPA only take out down to 0.3 microns. Viruses are smaller. So for that, I think a system with a photocatalytic oxidation system in the ventilation system, if at all possible, but certainly within the rooms, will destroy viruses. So that sort of technology in your HVAC system has a double thing. It not only eliminates the VOCs, it sanitizes the air. And the UV does not come out of the units because the UV reacts when it hits the first surface, so it doesn't come out. And these units do not generate ozone, and in fact they will, under testing, they've been shown that they actually absorb ozone from the atmosphere. So photocatalytic oxidation, PCO technology, is a great way to go.
But this is a system that you have to build up your air system with this in it, or you can adapt.
They can be retrofitted. There's Fred Zander developed all this stuff, but there's a thing called a Peacock 3 which you can install in your ventilation ducts. They could be retrofitted. You may want to put several in, depending. I mean, I have a separate seminar on air quality and things, but you could put those in. Even just within the room, though, you could also reduce virus floating around in the room by using the small floor standing ones that I showed on that slide, one of those units. That was the Zander 100C, used to be called the Ziffair. So those devices are readily available, and you can put those into your HVAC system or have the floor standing ones. We usually do both. We usually put them in the ventilation system and also have the floor standing ones in the lab and in the collection rooms. We've been doing that for quite a few years now because they also remove the smells between patients.
Oh, I'm going to ask the reference of that to my email. I have a question. Yeah, I have a question from Christina Magli. She says here, ESHRE recommends serological testing for SARS to now start ART treatment. You must know that. Huh? You said that you said that serological testing is not reliable, meaning that you disagree with the recommendation.
I think what I'm saying is that if you're testing for antibodies, a lot of the tests are not turning out to be that reliable. You need to know the reliability of the test that you're using. If you've got one that is accurate, then absolutely, it's good. But if some of the tests that have been, well, a lot of them here in North America, there's been a lot of them put on the market, and a lot of them have been withdrawn. False negative rates of 50% were not uncommon in some of these tests. So you need to know the test you're using. If you have got a test available to you that is able to give you numbers that you can trust, then absolutely you can use it. But it would still be better to be able to do PCR testing rather than just looking for antibodies.
Yeah, but the question of the PCR is also when, and because you also have to look at the days that you're going to do this PCR. You cannot be so far from the egg retrieval.
Yeah, and those protocols need to be developed in collaboration with your local infectious disease people and your public health people. They will tell you what's appropriate in your regulatory area, but certainly it's not a one-off test. People are looking at doing it 2 or 3, even 3 times before the patient gets to egg retrieval along the way. But there's also information that literally just came out yesterday or the day before that's suggesting that a lot of the people who are infected but non-symptomatic also have a much lower excretion of virus. So the world might not be as dangerous as we think. This is a rapidly evolving area. You need to be keeping on top of it, but we are reproductive biology experts. We should be deferring to the infectious disease experts and the public health experts. And so long as we do that and continue to update that with those people, that's the way to go forwards. We can't just issue a directive to everybody and say, this is what you're going to do, and everybody keeps doing it, the same forever. This is rapidly evolving. Things will change.
Yeah.
And so, ESHRE has recommendations. I read them. They're one of the many documents I've read as well. But it depends on the test itself, and you can't just say it's a test. There are literally, I think, more than 200 of those tests were released in North America over the last 3 months.
Exactly. Here in France, it was not allowed because effectively we didn't have a good test. Now apparently Roche released a good one, and you cannot generalize. I agree with you. Now I have a question here. We are talking about limitation of patients. So there is somebody who would like to know at this period now of the COVID, how many patients you would do retrievals? How many patients you would limit to? And the time between patients, actually.
That will depend on the size of your facility and how it's configured. If you're used to doing your retrievals, I've audited many clinics, and I've seen the number of retrievals per hour ranging between 1 and probably 8 or 10 in some places in the same rooms. The stuff of 8 to 10 was like a ballet. It was amazing to watch. But you have to look at the need for cleaning and the risk of patients meeting each other outside the procedure room. It's a question of how you, what space you've got. And then you've got the recovery space. Is your recovery space all in one room, all in one big space? Does it have partitions? So you can separate things. How long does it take to clean that space down between patients as well? You know, that will govern what you can do, and you need to look at how you can make that work. And you may have if you've got space for safely to have, well, if you have a space for the recovery space, they'll take 6 patients, but now we'll only take 3, with you know, leaving a space between them to increase the space, and you put up screens, whatever. Then just look at the flow. If you've got 3 patients going through, how long do you do egg retrievals? Every 20 minutes, every 30 minutes, every 60 minutes? Look at how long they go through and how long they recover for, and just plot it out. Create a flow chart, a timeline, and then see how you can flow the patients through. And then when you work that out, then look at the lab and see how many ICSI rigs you've got, for example, and how you can control the flow at that end as well. But this needs to be a totally collaborative thing between the people managing the procedures area, the recovery space, and the labs. And it's going to bring everyone to focus a lot more on planning how you do things and looking at timelines, and being careful about scheduling and making sure that things are done in a proper sequence.
Yeah, Dave, there is a question that comes back here 3 or 4 times. Would you separate tanks for the COVID positive patients for the cryo storage?
Personally, we wouldn't bother, because if we're using high security devices, we already don't even use quarantine tanks. We can store anything anywhere, because the devices are virus proof and the seals are virus proof. So it doesn't matter. It depends on the packaging devices. But how much virus is in semen, we don't know. And whether the risk is of transmitting, we don't know what that is either. The cross-contamination between storage, vapor will be slightly less than liquid, so it depends on that again. But at the end of the day, if you sanitize the outside of the device before using it, you should be safe. It depends on your practices, but it depends on your devices as well. So it's not a simple answer. The only really simple answer is, if you use high security straws for semen, it does not matter. And sexual transmission of SARS-CoV has not been reported. One would anticipate that SARS-CoV-2 will not be transmitted in the same way either. We don't know if the virus would need to be inside the sperm, which is not a usual thing. So if you process those samples also then using a density gradient with that ProInsert device, that is a safe way of handling HIV or sperm samples from HIV men, for IUIs. So it would be a perfectly safe way of handling it for IVF, for example, or well, certainly one for ICSI. So it's not a simple answer, but there's a number of things. You've got to look at your systems and see where the weaknesses lie, and how you might resolve those. And it's going to depend on what you're doing now or what you think you're going to change to.
I have the alcohol comes back all the time, so we are really clear on that. No alcohol, huh? Tell everybody no alcohol.
Yeah. The only alcohol used by embryologists should be after work.
We can drink it. Yeah, we can drink it. Listen, Brian, in the happy hour, Brian asked a question here. Do you have to leave the tank to air dry after the cleaning of the cryo storage tanks? He came to that one.
I said you leave it dry.
What?
You wash it out, then you rinse it, then you use whatever sanitizing agent you're using. And if you want, you can use alcohol, because you're doing this outside the lab in the cryobank. I was using it somewhere entirely separate. But you could use a form of bleach or whatever, but it must dry again, and so that you're not just going to freeze all that stuff inside the tank. So you let it dry, and then you slowly refill the tank. You got to take time refilling the tank, because if you fill it quickly, you run the risk of creating metal fatigue and stress in the structure of the tank. That's normal practice for filling a tank.
Yeah.
And you can't sanitize dry shippers.
I have now we are I have a last question here that came back as well about the thawing of the straws.
Yep.
How should you decontaminate to the decontamination of the straws? Should you decontaminate the straws? How to deal with the warming process actually?
Well, it depends on what you're looking at. Are you looking at vitrified specimens or slow frozen specimens?
I guess it's vitrified, don't they? Come on.
Well, it depends. If it's oocytes and embryos, they're going to be vitrified. If it's going to be sperm, they're going to be
frozen sperm. Yeah, it's true.
If it's frozen sperm, you wipe down the outside of the packaging device with something like Ursafe. Can't use alcohol, because alcohol, actually some of the old straws were permeable to alcohol, so you would never use that. But you get it out, you thaw it. Now, thawing slow frozen specimens, you should thaw them in a water bath, 30-degree water bath. We're moving the straw around, having a circulating water bath. And once it's thawed, before you breach the device, before you cut it, that's when you sanitize it. And then you expel the material from the straw into your dish or tube, whatever, without being careful not to allow the outside of the device to come into contact with the inside of whatever the container you're putting it into. If it's vitrified, again, we prefer to use the HSV device, and the inner thing is removed and is never come to contact with the outside. So it's the same issue, but you have to achieve your very rapid warming. So that's how the HSV device stays immersed in liquid nitrogen. Take the top off, then remove the carrier device from inside straight to the dish. There was no sanitization is not required in that. With other devices, you have to work with appropriate. I think we've got, your big problem now is anything that's not closed is going to be a problem. And certainly if that's how you've got your tank set up using those devices, anybody who you've got potential infectious cases should always have been stored in separate tanks anyway. And so yes, do you now need to have a separate SARS-CoV tank as well? It's quite likely that that's where you would want to go. But again, remember that if you're separating these infectious organisms, technically you should have a tank for every different combination of infectious organisms. You don't just have one tank for all the infectious ones. So again, that was why we took the decision years ago to go with the high security route.
Listen, Dave, unfortunately, we have to wrap up there. We passed the time. I wonder if you could perhaps answer the questions that I couldn't pose to you, because there are some by written, perhaps. Could you do that?
For some, if you've got 150 or 200, the answer is probably not.
No. But there are some. But we are not going to have more time to go on. I had already an alarm telling me wrap it up.
if you curate those questions, I will happily provide some written answers back to you, and you can post them or circulate them as however you want to do it.
Okay, perfect. Listen, thank you so much. It was very clear. It was a pleasure to have you, and I hope to see you soon in persona. And I
love that. My life hasn't been so quiet for traveling 45 years.
And I say goodbye to all of you. Keep safe. Take care.
Okay. Thank you very much. Bye-bye, Daniel.
Bye. Thank you very much, Dr. Nogueira and Dr. Mortimer. We will post this webinar on our Estuary website as well, so you can all find it there, and you will also receive it in your mailbox. Thank you again, and have a nice day.
Thank you. Bye.
Bye.
Bye.